Sorry you guys had to come to this. But we'll get it done, we'll get some education in. If you don't walk away from this a little bit more confused than when you came in, I didn't do my job. Because this is an interesting and very dependent topic on who you talk to. So anyways, subject, go back a little bit about myself. Was born in Salt Lake, grew up in Arizona, came back to Salt Lake for school, went to University of Utah, hate BYU, sorry. Then moved out to West Virginia for medical school. And is anyone from West Virginia? Good, I can make fun of it. West Virginia is a great place to learn medicine because everyone and their dog has a problem. Not so great for dentists because no one has teeth. And so did school there, and then I did my residency in Ohio, just up north of Cleveland. And then came back here, worked over at Ermac for 8 years, and came over here for the last 3 years. And that's where I'm at. Have 4 kids, 2 dogs.
We've been open more than 3 years, by the way.
Oh, no way. Have we? 3.5?
Over 4.
4?
4. Time flies. You're having so much fun.
I need to go think about my life decisions. This is not a lecture, nor do I ever want to be a lecture, because I hate lectures. I've probably been to more lectures than all of you been combined. Maybe not, but I'll pretend. So it's truly a question and answer and a discussion. So please participate, because I don't want to sit up here and ramble and have my mouth dry for an hour. So anyways, any questions to start off with? Any comments?
Is hypertension bad?
Depends. Well, let's start there. What's hypertension?
High blood pressure.
High blood pressure. So what's the difference between high blood pressure and hypertension?
Depends where the patient normally sits at.
Wait, what? Speak up.
Depends where the patient normally sits at with their blood pressure.
So the chronicity of it. So how long you have it. So blood pressure is just take a blood pressure, and hypertension is the chronically hypertensive. So that's the difference between hypertensive and blood pressure. So how many here is, who takes a blood pressure almost on a daily basis here?
Like our own?
I take my own.
Anyone's.
I don't think mine, I know what it'll be.
It doesn't help when you know that it's bad. You'd be a hypertensive. You wouldn't just be blood pressure issues. Okay. Hypertension or blood pressure is one of the 5 vital signs. 6 if you count pain, which we don't like to count anymore. But so there's 2 numbers with blood pressure. Does anyone? Come on, tell me, spit it out. What are the 2? Top and bottom, I like that. That's very good base. Getting up, we got the systolic on the top and the diastolic on the bottom. Now, who wants to raise their hand and tell me the difference between the 2, or how we calculate the 2 and the difference, essentially? We got it, Jeremiah.
So systolic is the pressure with contraction of the heart and the pressure as it goes through the arterial system, and then your diastolic is at rest.
At rest.
Contraction.
Yep. So no matter what in your body, you have always pressure. Systolic is when it compresses, diastolic when it relaxes. Hey! There was only a few people that asked me about this one. Okay, so systolic is when it contracts, and diastolic is when it relaxes. So when it contracts, we always have a higher blood pressure than the diastolic when it relaxes. So with that, let's go on to this beautiful graph right here. It's the American Heart Association. It's the good old graph that's been around forever. Can you guys read that in the back?
Yeah.
So essentially, normal is less than 120 on the top, less than 80 on the bottom. And those are actually changing nowadays as well. So just to confuse it all, these are going to be changing as well. But for the moment, this is what we got. Elevated 120 to 129, and then less than 80 on the bottom. High blood pressure, hypertension, so the chronic stages of blood pressure, 130, 139, 80 to 89. Everyone's at, just to let you know that we see. We're probably 3/4 of that in here. Hypertension stage 2, 140 or higher, 90 or higher. Hypertensive crisis is higher than 180 or 120 on the bottom. So, and then there's hypertensive emergency, which isn't listed on there because they probably don't see it a lot, but that's anything over 220 and above on the top number. So what's more important, the top number or the bottom number?
Bottom.
Bottom? Why?
You want your heart to have time to relax.
Kind of wrong, but we'll take it. Any other guesses? There's no wrong answer.
Because that's when your
You can't answer
heart fills
again.
with blood. Well, I gotta redeem myself. So. When your heart has time to fill with the blood, that's
So
then
you're
blood
thinking
goes.
too hard.
Oh,
Too hard. What's more important, the top or bottom?
I like the top.
The top? I like the top too. Anyone got any other guesses? Okay.
I'm gonna say I can't explain it, but the mean.
The mean. Does anyone calculate the mean? Does anyone know how to calculate the mean of the blood pressure?
That's what it's doing about machines. That's what the machine does. I'll put a stab at it.
I think it's
great.
There you go.
it's the systolic times a third, and then the diastolic is 2/3.
And then you divide by. Get your math.
Rock star.
But anyways, yes, you can go by MAP, mean arterial pressure, the median. With that being said,
They're equally important.
I will. Who said that? Wow. Wow. They are equally important. That's why we have two lists up there that go down and says what they said. So, did you not get a $2 bill? Okay, let's go into a practical view of things. No passcode. 2705 for anyone who wants this iPad. Sorry. It's mine now. All right, we're going to go through some real world applications, and in fact, some of y'all were probably. What? Well, that ain't going to work. Okay. I know this is old school, but can everyone see this? Ish. Okay. So some of you guys might have been involved in these cases recently. For HIPAA, we won't use names. With that being said, let's go over a couple cases, okay? So we got a 34-year-old gal. Who came in with DKA, went to the ICU for 2 days, came out to the medical floors. And on the medical floors, she started to develop lethargy. And so one of our wonderful nurses called a rapid response. And nurses, tell me what happens in a rapid response. Everyone comes in. It's a madhouse. It's crazy. But what are some of the things you guys start doing to the patient to kind of figure things out?
Take a blood sugar.
Okay, so we got blood pressure, sugar. Can you guys remember this without me having to write it?
Yes.
Thank you. We're all smart here. So taking a blood sugar. Anything else?
How the patients do.
I like it. So she is lethargic. She is essentially blowing spit bubbles. You poke her and she might move a little bit. Blood sugar was normal. We took a blood pressure. It was 134/78. Anything else?
Oxygen.
Oxygen was 92% on 3 liters.
ABG.
ABG was normal. Her DKA was resolved 3 days after. So, in this real world scenario, as we were met coding her, or rapid responsing her, she looked medically stable. So, a couple of us were outside the door letting people do their thing. And we noticed that the blood pressure cuff was not on her arm. We noticed it was on the bedside rail. And the machine took the blood pressure, and it was 134/78. Right?
That's wonderful.
So there's one thing, just a little bit of info. Look at the patient, look at what's going on, kind of get an overall view. Something's weird. Look at it and fix it. Okay? So, next one, 78-year-old gal comes in with broken hip. Pick whoever your favorite orthopedics is. He or she, there's no she ones there. He or she went and fixed it. Comes back and stays day 2, status post-op. She is in pain. She's hurting, obviously. She had a hip fracture. She's getting up to work with physical therapy. And her blood pressure is like 180 systolic, the top number. So they call the doctor, and the doctor evaluates the patient. And we found that she had her fluids continued running for the last 3 days at about 125 an hour. So if you put extra fluid into a closed system, that blood pressure is going to be high. So what do you think we did? Stopped the fluids and diuresed her. Her blood pressure was great. Same situation, except the fluids weren't running for a few days, and she is still hypertensive. She's 180s, and normally she's in 120s, she says at home. Still with a broken hip. What was that? Pain. Pain's another good one. So those are a couple of just real world scenarios that we actually see quite a bit. The one on the bed was just that one occurrence, but that was pretty funny. So before we get into the nuts and bolts of things, but why do we treat blood pressure? Why do we even care?
It's too high, it's risk of stroke.
Risk of stroke, okay, I like it.
Oh.
Gotta walk all the way to the back. Risk of stroke, okay. Why else do we treat it? What?
Heart attack.
Heart attack, MIs. Anyone else? What?
It's too low, like you can go and die.
I'll take that.
It's bad too.
An acceptable answer. Thinking outside the box. The end game. Okay.
So just, I mean, multiple organs are sensitive to pressure.
Which ones?
So you do kidneys
Kidneys.
specifically.
Okay.
So you do damage to the intricate features of the kidney that impair its ability to function.
Okay, so kidney injury, we got the heart, we got the brain, okay, brain stroke. So if you think, the way I think about it, is that the small vessels in our bodies, if they have the higher pressure, they aren't going to do as well. So eyes, heart, kidneys, stroke. Those are all reasons why we treat blood pressure. But getting down to one step below that, we'll get a little bit more simple. Who here lifts weights?
Used to do it.
What happens if you lift a ton of weight for a long period of time? What happens to your hands? They get calloused. Why? Because they get beat up so much. Blood pressure is the same way. If our blood pressure is too high, our body takes a beating. Our arteries take a beating, and they become thickened. So if our arteries become thickened, our blood pressure goes higher, and also there's risk of stroke, there's risk of heart disease, there's risk of kidney failure. And also aneurysms. If we weaken or thicken the walls of our vessels, it's not our natural way of things, and so it can get aneurysms. So that's why we treat blood pressure. So let's go over when to treat it. So this whole lecture is when to treat hypertension in a hospitalized patient? Does anyone want to take a guess?
They're symptomatic.
I like symptomatic. Okay, let's go over symptoms. What are symptoms of high blood pressure?
Headache.
Headache.
Visual changes.
Blurred vision, shortness of breath, nausea, chest pain, diaphoresis. All these can also be a sign of blood pressure issues. With that being said, blood pressure is also called the silent killer because you don't really know you have it until these things start to happen. You go to your doctor or whatnot and they find your blood pressure is 200 and then you're in trouble. So those are the symptoms of blood pressure. So yes, we treat it when people have symptoms. Let's do another real world scenario. So nurse calls up, just a normal person on the floors. Blood pressure is 180 over 90. Patient's completely asymptomatic. Does that nurse need to call us for any reason to get some blood pressure medications?
Depends on previous.
What?
Depends on previous blood pressures.
I like it, okay. Outside the box thinking, looking at the big picture. So previous blood pressures, what if it was normal yesterday and abnormal today? Warrants a call, right? What if yesterday it was 160s and today it's 180s?
It's trending higher.
You're still starting to trend up, so you should probably call and just at least say we're trending upward.
That'd be decent. So do nurses have a like a motto, like doctors like say, do no harm? Do nurses have something like that, like a creed?
It's the
I think it
opposite.
goes blame the doctor.
It's the opposite.
And that's where we stop.
We're done.
We're done. So yes, we try to do no harm, at least the doctor-wise. Nurses-wise, I think your creed should be something around the do the best for your patient. So if you guys are ever concerned, there's no reason you can't call. We might be grumpy, we might yell at you, whatever. With that being said, you did what you need to do for your patient. You can feel good about yourself, although we probably don't feel good about you. But let's try maybe save us some calls. Maybe. So no matter what, you're going to call us if you're concerned. But, so there was a couple articles that came out in the last couple of years. There was a little thing called COVID the last couple of years that kind of overshadowed everything. And so these journal articles and stuff like that have not been really been used too much for the fact that no one's been reading journal articles on blood pressure or anything else besides COVID for the last couple of years. So anyways, this journal article was produced in the JAMA, Journal of the American Medical Association, that we read fairly often. Very reputable article and magazine. So with that, they got 22,000 adults, which is pretty darn good for a cohort study. And they all were hospitalized, all with different things, but all of them were non-cardiac. So they had no cardiac issues that they were aware of. They were admitted to the hospital, they were treated for whatever. So in the hospital, they did two things. One, they did not treat, and then two, they did treat. Anyone have any suspected ideas what happened?
Falls increased for treating blood pressure.
Not sure about that, but
The outcomes were the same.
Yeah.
the outcomes were the same. You'd be wrong. The outcomes were different. Oh, who was it? Oh, sorry. I'm deaf and blind. The outcomes were actually quite a bit different. The blood pressures that were treated, and it doesn't even say what the blood pressures were. They said any blood pressure that was treated in the hospital had worse outcomes than the ones that weren't treated. Not only during their hospital stay, but also post-hospital stay. Anyone think of why post-hospital?
It's a situation that's not normal for them, which can cause an increase just in anxiety and pain and all the different things that go on.
Completely
So when they
agree.
get back to their normal state of homeostasis, they are lower than they should be or not in target.
Everyone hear that? Okay, so Jeremiah gave a great answer. Does anyone have a dumber answer?
We come on drugs.
I like it. We put them on drugs. We put them on extra drugs. They're in a situation where, I'm blind, sorry. They're in a situation they aren't used to, and then they go home on these drugs, and us stupid doctors keep them on those medicines, and then they crash. So they get hypertensive, they have their falls, and they come back to the hospital. So the confusing portion is, when do you treat blood pressures?
When treating, you should also educate too.
So you treat them when they're symptomatically or having end organ or other issues directly related to blood pressure.
So cardiac disease. So thickened arteries, we want to treat those. So here is the other confusing part. What if it's 180 systolic? Do you call them if they have cardiac issues? Do you call, find them, get some blood pressure medication? It's patient dependent. If they're having symptoms, yes. If they aren't, maybe not. So, have I confused y'all yet?
That's why we call you so much.
Touche. And the reason you call us is you're concerned, right? Can anyone fault you for calling us if you're concerned? Especially if it's in the best interest of your patient. We can yell, we can scream, we can cry. But if you're doing it in the best interest of your patient, there's no fault in it whatsoever. Right? So, why did I give you $2 bills? They're real, by the way. They're an oddity. Same with blood pressure. If you get a weird blood pressure, it's an oddity. Take a step back, look at it. I think that's a little bit on the odd side. Maybe it's on the rail and it's taking the rail's blood pressure. Maybe it's on the foot and it's not reading correct. Maybe the cup is too big or too small and it's not reading right. Just like a $2 bill, take a look back and say, there might be something funny about this. That's why the $2 bills. It's also fun to give like a 16-year-old $2 bill because they don't know what the heck it is. Try paying for that at a store, it's hilarious. That's blood pressure. Any questions?
What about permissive hypertension?
I love it. When do we do permissive hypertension? Strokes. So what's the permissive hypertension supposed number?
Above 180 systolic at 220.
220. 220, guys, that's huge. If anyone saw a 220 blood pressure and they didn't call us, we'd be like, it's a little weird. Strokes are different because they aren't perfusing their brain. So with that 220 blood pressure, we need it to attempt to perfuse the brain. How long do we leave it permissive in strokes? 3 days, 2-3 days. Depends when they had the stroke too. Depends if they got TPA. A lot of variables. So that's permissive hypertension. The other probably permissive hypertension is orthostatic hypotension, where they stand up and they get really low. We take off all their medications and we try to get their blood pressure up a little bit so that when they stand up, they don't drop too low. There's probably a couple others. Anyone else think of why we keep the blood pressure high? Maybe they were high in the past and we don't want to drop them too fast. So if their normal systolics in the 200s has been that way for years, if you drop them to a normal blood pressure of 120, they are not going to feel good at all. So stepwise, slowly get it down. And that's where your primary doctors come on board, where they can watch them as an outpatient and adjust medications accordingly. So I like permissive hypertension. technically we should permissively hypertension everybody in the hospital besides cardiac patients. But we don't. Any other questions that I cannot answer?
How do you treat a blood pressure that has no history?
No history, so first coming in,
Person comes into our ER, they want to be seen, you can tell that they're nervous, you've never seen them before, you don't know their history, you ask if you can take your blood pressure at home, they say no. It's a high blood pressure, they get admitted upstairs, it's still high, but they don't have no history, but now you're guessing yourself if that's their normal range, or is that something that you feel like it needs to be dropped? How do you,
so how high? Let's start there.
well, where it make you nervous, like if it's in the 160s to the 180s, to where you know that it's not normal and it's not coming down, but you're trying to guess, with their history of.
If they have a history of
Yeah.
it. So technically, you shouldn't treat it. They're in a different situation, they're in a stressful situation, that blood pressure is going to be falsely elevated. With that being said, if they're in the hospital for a couple of days, we can watch it pretty closely and see if it goes down. We might, if it's new onset, we might be able to start just a low dose of lisinopril or something very simple that we should, and have their primary care doc follow up with it. But it's not uncommon for us to send somebody out of the hospital with blood pressure 160s, 180s. It's not uncommon. So should we treat it? Technically, no. Do we treat it? Yes, because we get nervous.
How does, right now, that communication happen between our hospitalists and family docs? How do we make it better? How does it happen now? I have multiple questions.
Please do. Right now, we don't have a great system. We just call. And if they come in, it's a rarity that, well, I shouldn't say rarity, but it's a rare occasion that someone comes in for just hypertension, just blood pressure. There's usually another issue, broken hip, infection, those type of things that might be driving the blood pressure. We send all our stuff over to our primary docs. They have access to all the things we did in the hospital. And on the discharge summaries, we have a list of medications that the patient should and should not take or whatnot. So, do they get it? Yes. Do we know that they got it? Yeah, sometimes we don't. And that's just the honest truth. That's just medicine.
Sometimes we use the rule like plus or minus 20 to get them back out of the hospital. And if they came in at 168 and then you go home at 186, does that plus or minus rule work to what number? And how would you treat it?
Everyone's different on that one. Like 186, I'd get a little bit nervous with sending someone out because you're getting up to hypertension type 2. It's getting up to urgency/emergency. So yes, I would probably treat that. In fact, I've kept the patient or two just for the fact that their blood pressure is that high, and I have no good reason for it to be that high. I watch them overnight and then send them the next day, depending on what it is. So again, patient dependent, doctor dependent. Hence the confusion. Okay, does anyone else want a chance for a $2 bill? Gotta ask a question. Jeez, I'm just gonna spend it on the pizza party or something. Has it been confusing enough for you? Essentially, I think, in summary, that you guys are all nurses, clinicians, whatever you are, you're the advocate for the patient. If you feel uncomfortable with anything that the patient is showing, any vital signs, whatever, you guys are the advocates for them. And if you're uncomfortable, it probably means we should be uncomfortable too. So, not always. With that being said, we're always concerned.
So I would just say on ER, is there a difference between those criteria of when to treat and when not to treat out of the ER? Because most of the journal articles that I've seen, permissive hypertension unless they are in hypertensive crisis or emergency.
Yep. That's what I read too. I obviously focus on the inpatient side of things, but I would assume the ER is even worse. You see hypertension a heck of a lot more, and it's a lot more.
Pain, anxiety, all the things that
Their
policy
height.
elevate that.
Yeah.
Unless they're having significant system or symptoms or are in that hypertensive crisis or emergency area. Because we'll have the charts reviewed and, they had a pressure of 160 or 165 and you didn't do anything to treat it. And that's actually based on appropriateness. It's not appropriate to, we should let them be permissively hypertensive with follow-up, with a primary, to follow up on, hey, your blood pressure's elevated today. You probably need to follow up with somebody.
Yep. And if you put them on some medications and they weren't hypertension, like we were saying before, they go home and they're hypotensive, they fall, break a hip, whose fault is it? Ours.
Do you like PRN, hypertension, anti-hypertension orders?
No, because they only last for a certain amount of time. It's not fixed, it's a Band-Aid. If you called me particularly for an elevated blood pressure, I'd look at their home medications and see what they were on and see if I could adjust those first. If I could do an adjustment, like increase something, that's what I'd do first. IV stuff, it's for hypertensive urgency, emergency, symptoms. That's my thought process. Other people's might be different. I personally like clonidine patches because it lasts. But again, it's one of those things, are you going to make it worse on discharge? Technically, according to 22,000 people, it will. So you got to be cautious.
If you do discharge somebody on an antihypertensive, do you have a go-to, or is it a patient specific?
Patient specific. Yeah, because if you have BPH, you do like temsulcin or something. I try to kill two birds with one stone with blood pressure. So if they're tachycardic and hypertensive, I try to use a beta blocker. If they don't have swelling in their legs, I want to give them swelling in their legs. I can use a calcium channel blocker. Some people got problems. But yeah, I try to do patient dependent on what they have. So, all right, Gabe, did I give you two? Yes. All right, yeah, sorry.
So one of the things that we kind of with Muse and some of the other stuff we've tried to implement and educate to is trending. Trending vital signs, trending. So if we're trending blood pressures,
Okay.
and we kind of know where they came in,
Okay.
but we're educating them. So are we going to use mites plus or minus 20 as we trend it? So we've trended from 140, we're now at 160. Now maybe we're at 170, 175. How do we educate to the trends, and as they're watching the trends, watching the vital signs, when they need to start getting a little more keying in, saying, this is getting bad, I should call?
So if you're saying I should call, you should call. And that's, again, it's dependent. Because if I come in with blood pressure 120, doing great, I go to the bathroom, I have a fall, my blood pressure is 160, you're going to call me because of that? It's trending in the wrong way, but there's a reason for that. Always, again, like the $2 bill, take a look at it, it's a little bit off. Why? Ask what? Why? Have they been on fluids for 3 days? It's just because they've been on fluids and they're eating and drinking appropriately and some dumb doc forgot to take the fluids off. Very possible. But again, if you can take a look at it and kind of work it out and see if it's a trend because of something, do you need to call? Yeah, it depends what it is. But again, if you get nervous, there's usually a reason why. Give us a call. Let us make the decision. Let us get the grunt. Let us get sued. So, fair. Is that even an answer to your question?
Back to what Casey said, blame the docs.
Blame the dogs. Yep.
So
It always goes to the top when it comes to medicine.
So we're talking specifically for blood pressures. What about what other vital signs might correlate with the blood pressures in the trends?
So that's a tricky one, because not even sepsis. Sepsis criteria doesn't even have blood pressures unless it's septic shock. You don't even test them. all the I mean, the vital signs are, all the vital signs do are show how the patient's doing. If they're trending bad, you're going to obviously know the patient's not doing well, but you can take a look at a patient and say they aren't doing too hot just by looking at them. So the trends are hard, because if you, and with relation to the vital signs and the blood pressure, they're all independent. Well, I shouldn't say independent, but you know, if you have a fever, you aren't feeling good, your blood pressure is going to be a little bit on the elevated side for the most part, unless you go into shock and then it goes down. So again, it comes back to the patient independent, or depends on the patient, and also depends on nurse, depends on your tolerable level of comfort, and if you don't feel comfortable, pass it up the chain.
Does the regular blood pressures have to anything, can you correlate your regular blood pressures with, and I think sometimes in the fall committee we see maybe something that happened with orthostatic blood pressures when they're getting out of bed and they're in bed all day and then they get out of bed and they fall. And I think because their blood pressure drops, and I'm wondering how that can relate to their blood pressure, or there's no relation, and how to prevent a fall, because that happens quite a bit.
That's hard. That's a tough question, because everyone's independent of, you know, orthostasis, orthostatic hypotension has a definition. It doesn't matter if they fall or not. If they're orthostatic and they don't fit orthostasis because their blood pressure goes low and they fall, they're going to treat it anyways. How to prevent that? It's a good question.
Well, I mean, a lot of times the patient falls, and when we show up in the room, he's already fell.
Yeah.
So a lot of times is we don't recognize that it could have been orthostatic blood pressure, that's why they fell. And so I think it goes undiagnosed.
I bet you it does. I bet you we do quite a bit. But again, that leads back to the adjustment of medications. If we adjust medications, for example, they're hypertensive while they're laying in bed and they stand up and they get orthostatic and fall, that's why we go do vitals right afterwards and see what it is. Usually it'll be low if they're orthostatic. But again, did we treat blood pressure with a systolic of 160 2 days ago, and now we're just seeing the results of us being stupid because they fell? Very dependent. Can we prevent falls?
Yes, we can.
To reduce them.
Yeah. I almost fell right there tripping on that. That almost was a rapid response. Yeah, you do your best. Nothing's perfect. You try. Okay, other questions, concerns, stories? Anyone do anything fun this weekend? Okay, with that, call us if you need to.